For decades, right, we've all heard the story. Depression is a chemical imbalance in the brain. But what if that simple story, the one that launched 1 billion prescriptions, isn't the whole story? Well, let's dive in and really unpack what the science is telling us now about the true nature of depression.
I mean, listen to this quote. What? What? Psychopharmacologist Dr. Stephen Stahl really captures the shockwave that's hitting psychiatry right now. The idea that our main tool, our go-to treatment, might not actually be the best thing for a lot of people, that's a huge, huge shift. So yeah, how did we get here?
Okay, so to really get where we're going with all this, we've got to look back at where we've been. And for, more than half a century, the story was all about serotonin. It was simple, it was powerful, and honestly, it made a ton of sense back then.
Believe it or not, this whole thing kind of started by accident. Back in the 50s, there was this drug for tuberculosis, iproniazide, and doctors noticed something really strange. It was making their patients happier. Well, scientists dug in and found it was boosting brain chemicals, like serotonin. Then, not long after, another type of drug, the tricyclics, did pretty much the same thing. So by the time the 80s rolled around and we got SSRIs, drugs literally designed to raise serotonin, the hypothesis felt like it was set in stone. It was fact.
So the core idea was just so simple, right? Low serotonin causes depression. The logic was easy to follow. If we make drugs that raise serotonin, we can fix the depression. And that chemical imbalance story, it became the story. It's what doctors told patients, and it's what millions of us came to believe.
But, like in any good story, there was a plot twist. As the science got better and we learned more, researchers started finding things that, they just didn't fit. This nice, simple story started to fall apart. You could see the cracks starting to show.
And what's so fascinating is that the evidence against it came from all over the place. For one thing, study after study, they just couldn't consistently find lower serotonin levels in people with depression. Okay, so then they tried flipping it. They'd artificially lower serotonin in healthy people to see if it caused depression. And it didn't really work. But maybe the biggest head-scratcher of all? SSRIs get to work boosting serotonin in just a few hours. So why in the world does it take weeks, sometimes months, for people to actually feel better? It just didn't add up. Something else had to be going on.
So that brings us to the big question, right? If it's not just a simple chemical imbalance, then what is going on? And this is where everything starts to change. The search for an answer has shown us that the real challenge isn't just finding the right pill for the right chemical, it's about deeply understanding each person's unique situation. And that starts with getting the diagnosis right in the first place.
See, the way we think about it now is that mood disorders aren't these clean, separate boxes. It's much more like a spectrum. You've got pure depression on one end, pure mania on the other, and this huge, messy, complicated range in between. And that's what makes figuring out what's really happening with someone so incredibly challenging. Okay, let's just take a look at why this is so important. You could have two people walk into a doctor's office. One has unipolar depression, the other has bipolar depression. And on the surface, they might look exactly the same. They both feel awful, they're both depressed, but underneath, the biology is totally different. Look here, the age it starts, the sleep patterns, the appetite, and most importantly, how they react to antidepressants. You give a standard antidepressant to someone who actually has bipolar disorder, you might as well be throwing gasoline on a fire. It can make things so much worse. And the stakes here, they couldn't be higher. I mean, just look at this number. The risk of suicide for someone with bipolar disorder is 20 times higher than for the general population. This isn't just about getting the label right. We're talking about life and death.
So how do you get it right? Well, Dr. Stahl has this memorable piece of advice for clinicians. Who's your daddy and where's your mama? Who's your daddy is basically code for what's your family history? We know genetics play a massive role here. And where's your mama? That means you've got to talk to someone close to the patient, a parent, a partner, because people often can't see their own symptoms of hypomania. They just don't recognize it.
All right, now this brings us to a really critical idea in modern diagnosis. It's the concept that depression isn't always, pure depression. Sometimes you have these little bits of manic energy hiding inside a major depressive episode. And that hidden clue is what we call mixed features.
And Dr. Stahl has this incredible way of describing it. He says pure depression is like being bent over, just crushed by the weight of it. But depression with mixed features? It's like you're bent over, but you've got this buzzing, agitated energy that pulls you halfway back up. It is that horrible, awful feeling of being tired and wired. You're completely exhausted, but your brain just will not shut up.
And this isn't just, a vague feeling, it's an actual clinical diagnosis in the DSM-5. So to get this diagnosis, you have to have all the symptoms of a major depressive episode, plus at least 3 of these manic or hypomanic symptoms you see here. Things like racing thoughts, talking way more than usual, or a sudden burst of energy.
And you might think this is some rare thing, but just look at these numbers. About a quarter of people with unipolar depression have this, and for people with bipolar depression, it could be up to half of them. This is not some rare exception to the rule. This is a massive part of what depression actually looks like for a lot of people.
And this is why it is so critical to spot this. Because if you treat that tired and wired state with a regular antidepressant, it can be a complete disaster. Instead of helping, it can actually crank up that agitation, that anxiety, that inner turmoil, and make the person feel so much worse.
So all this complexity tells us we've got to zoom out. We need to think way bigger than just serotonin or dopamine. Depression isn't a problem with one chemical. It seems to be a problem with the whole system, multiple interconnected networks all across the brain.
Take the stress system, for example, the HPA axis. For a lot of people with depression, this system is stuck in the on position. It's just flooding the brain with stress hormones like cortisol, and over time, that's really damaging to brain cells.
Then there's the immune system. We're learning that chronic inflammation, the kind you might not even feel, can create what scientists call sickness behaviors. Feeling tired, not wanting to see people, not feeling hungry. Sound familiar? It looks an awful lot like depression.
And another huge piece of the puzzle is brain plasticity. Basically, the brain's ability to heal and grow. This whole process depends on stuff like BDNF, which is kind of like fertilizer for your neurons. In depression, those BDNF levels are often low, so the brain just isn't as good at repairing itself and building new healthy connections.
So, okay, the problem is complicated. It involves our genes, our stress levels, our immune system, the whole shebang. So, what do we do about it? Where do we go from here? The answer, it seems, is getting personal, really personal.
And that's why Dr. Stahl makes this bold claim. The word antidepressant is obsolete. It's outdated because it suggests there's one problem, depression, with one solution, an antidepressant. But the future isn't about one magic bullet. It's about having a whole toolkit and knowing exactly which tool to use for which specific problem. So what does this new approach actually look like in practice? Well, step 1, you deconstruct the problem. You don't just say depression. You say, okay, what are the actual symptoms here? Is it low energy? Is it anxiety? Is it trouble sleeping? Step 2, you try to figure out the biology underneath. Is this leaning more unipolar, more bipolar? Does it have those mixed features we talked about? And then, and only then, comes step 3. You choose a treatment that's targeted to those exact symptoms and that specific biology, not just the general label.
And all of this really leads us to one final big question. We started with this incredibly simple story of a chemical imbalance, and now we've arrived at this complex, messy, beautiful reality of unique brain circuits, genetics, and life stories. So it really makes you wonder, doesn't it? If every brain is different, shouldn't every treatment be different too?